Thank you, Arnie. Welcome everyone to this event this afternoon. What will data analytics mean for social care providers in the future? We are looking forward to good discussions with the panel now. I am Josephine Magnuson. I am the Senior Research Officer at Future Care Capital. Future Care Capital is a 70-year-old charity focusing on health and social care. We have the Queen as our royal patron. And our vision is to see all of those in receipt of care benefit from a functioning and fit for purpose health and care system. And to that end, we focus on 3 key areas of action. So we work with policymakers through our research and influence. We work with and support health and care practitioners, bringing together Future Care Capitals and others' research through projects and initiatives in order to inspire and encourage debate. And we also put our money where our mouth is, so to speak, by investing and partnering for social impact. Future Care Capital have been leading the community of practice for social care analytics since the beginning of this year. And that is a community that is run with support from the Health Foundation. And it is in that capacity that we are welcoming this event this afternoon that is led by Manor community. So I think with that, I'm going to hand back to Arnie, who will talk about how the Q&A and everything will work. And I look forward to an interesting discussion this afternoon.
Yeah, thanks so much. So a couple things. I'm Arnie King. I work for Manor Community and Coproduce Care, which is 2 separate organisations. Manor Community is a very conventional care provider, primarily to adults of working age for a range of circumstances related to capacity, mental capacity and complex needs. We do also cover older person care, and that is from home care, supported living and care homes. We have in the last few years, as part of me joining the organisation, built up a separate non-profit network, which is Coproduce Care. We do that specifically to connect providers together and help us sort of work together to promote the voices of people across social care into some important areas of decision making. As has been introduced there, we are now taking part in a project that's part of the Health Foundation and Future Care Capital's Improving Care Analytics sort of program. And I'll give some details about our project in a minute before opening up to the 2 panel members that we've invited into this event. The first of those is Matthew Todd. They work at Logan Todd Data's company. They are our sort of data helpers in the project. They're making sure that anything that us as a provider trying to do advanced data analytics and analysis is best practice and doesn't miss any sort of methodological issues. And we'll be talking a little bit about the tools that are involved in this project and this wider conversation we're trying to have throughout this event. Then I'm going to move to Katie Thorn, who works over at Digital Social Care, who's been engaged with us for a couple projects in the last few years, but we're going to talk a little bit more widely about the context of what digital technological advancements mean for the social care sector and how it might be different in different parts of the sector and how that might affect the learning, the conversations and the outcomes of projects exactly like this, where we're trying to improve the engagement and inclusiveness of different providers and parts of the sector in these decisions. I do have a few slides. I've done my presentation in a few places now talking about the project and who we are, but we're trying to keep this a little bit more informal, a little bit more open and a little bit conversational, so hopefully everyone feels quite confident in getting involved for the last 20 minutes or so to talk about what this means for them, their thoughts, views, concerns, and carry on that conversation, which is a huge part of our project, creating the engagement around this, creating that conversation and what that means for providers. So our project is a little bit of a partnership across a few organisations, but it's got one main aim, and that is to understand how well advanced analytic tools, namely machine learning, a very basic form of AI, can understand a very important group to social care. In our sort of terms of reference, that was originally people receiving the worst outcomes in care. Now, that is obviously going to mean something a little bit different to everyone in this room. We obviously had our belief of what that was, but as part of a project, what we did is we went to a local council here in Bristol and we said, well, this is who we think it is. What does your data suggest comes under the term of people receiving worst outcomes of care? And together we did create a fairly clear line that it is primarily adults with learning disabilities, autism, or both, but we have allowed input from a few sort of wider circumstances related to mental health and disabilities, or circumstances that affect sort of complex needs and mental capacity. Now, that's a hugely important group. We are speaking to them in a very open, sort of sensitive, accessible way, and just trying to get them to talk about care in any way, good, bad, general, specific. We're very, very clear that it's a very friendly, inclusive way of taking part in the survey. We don't ask for anything private or serious or sensitive. Make it very, very clear that friend, family member, carer can sit with them to sort of encourage speaking openly about what care means, what's been good and bad, but then not criticizing any specific provider, intervention, or part of care. It's just getting data that is, how does that group that one, receive the worst outcomes, but two, I think arguably are kept out of decision-making in care, maybe even more so than some other stakeholder groups that rely on care services in different ways. So the first part is what actually do those groups say? What does that tell us about care services, the way they're designed, the way they're commissioned, the way that councils and local authorities work across sector with different providers and different organisations in the sector? And what does that suggest? One, for specific changes. Do these tools lead to direct ways that recommendations for change on a regional level are clear? But then two, how well have those tools understood that group? What do we see are maybe dangers, clear issues, or just basic learning of common issues, common misunderstandings, maybe omissions, or ways that these tools analyze data that's going to affect the way that it represents that, again, really, really important group that is often very underrepresented in decision making for our sector. The final part of the project is to see what comes out of that testing. One, is there enough recommendations from that to make significant recommendations to a council? We have a sort of hypothetical council that we take our findings to for our pilot. Well, we're a council, but we're not expecting them to immediately make those changes. The point is we've gone from going out, starting the conversation, properly understanding how the tools have analysed what people have said about care, and then we're writing up what the process is of how effective that those outputs are, and what practically is a council going to actually be able to do with that. Our final bit of learning is, how do providers take part in this in the future? How do they lead on the way that it's going to be used? And how do genuine stakeholders of the sector have a real voice in the way that developments in data analytics are involved in care? Bearing in mind this could be affecting commissioning, monitoring, feedback, regulation. There's a load of different ways, but it already is affecting how the social care sector is run, let alone how government and society is run more widely also. But then the skills for learning, the opportunities, the platforms for collaboration between providers and local authorities, between local systems and national systems, between an individual on the ground and the sector that supports the social care sector and the way that it's developed. What can we put in place so that people feel part of a recognised, rewarded, sustainably growing career opportunity and beneficial provision of care to people across communities? So just to finish off, between now and August, I'm running around the west of England trying to get any provider that provides care to relevant groups to listen to me, understand who I am, what I'm trying to do, believe that we are honestly not just a very large sort of top-down change already that has to be done to be a part of something. It's genuinely a progressive idea of how progressive analysis of how providers can lead on these developments over the next few years. Get the surveys out in the most sensitive, appropriate way for each individual person, setting, provider, part of a region. And as I say, we've got everything from being able to write it on paper, speak to people on the phone, have a carer with you, maybe jotting something down, typing it directly into an online form, and we'll be able to support any variation of that. We get to late summer and we're seeing if it works. We're using very DIY off-the-shelf tools so that we can understand it and be very clear about any sort of fancy coding that would be needed for this to work, a proper assessment of how well they work themselves, and then a useful sort of mapping of the skills and provision that are going to be needed to make this work well for the sector moving forward. And then after the summer, hopefully the tools have worked very, very well, and we understand what people have said, and we have an understanding of how well the tools have understood those people and what the gaps are. And then between then and spring of next year, we go back round to providers, back round to different sector players and actors, and we say, this is what we've learned, this is what we're recommending, this is what we could take to a council. What do you want from this? What learning would make you feel a part of this? What activities, what support should we be recommending in this sort of secondary output outside of a report that says how well it understood people and what they said? This sort of skills and development mapping, what would work best for you, not only to be a part of this and make sure that it works fairly and accurately, but how does it promote proper collaboration across the sector so that different organisations at different levels have a genuine voice in what's going to be a huge development in sectors over the next few years. So that all made sense to me, but I've been saying the same thing every day now for the last few months. Hopefully that's starting to get you thinking about what these tools are and why it's important right now. I'm going to bring in Matthew Todd. He, as I've said, is a part of the project because we brought his organisation in as a partner to sort of hold our hand through using these tools to check that what I think they are doing is what they're doing, to have that conversation with us of how effectively they've worked, and what we can actually say, one, about what people have told us, and then two, how these tools are going to be used in the future. So Matthew, I can see you've unmuted. How are you doing this afternoon? Happy to be with us?
I'm delighted to be here, thank you.
Fantastic. Did you want to give a little background to the organisation and what's a key bit of experience, that i.e. sort of working with councils, and a bit of the experience you've had of seeing these tools being used already?
Yes, I think that's where this sort of originates, that I've been working with councils to understand feedback. So many organisations collect feedback in some way, shape or form, and there's a lot of it. The NHS actually runs the world's largest feedback programme with 1.5 million comments a month when it's running at full speed. And a council typically sort of somewhere in the region of 5,000 comments, 10,000 comments. Now that's quite a challenge for somebody to actually read and to understand. So the work that we've been doing is actually saying, well, can we use algorithms to pull out the key phrases? What are the things people are talking about? And in doing that work, we also found there were key phrases being pulled out where people were saying things that made you understand that they were vulnerable. So if somebody sort of says something, like I'm really depressed, or I'm just out of hospital, things like that, they put that into the comment. And at the moment, with the manual reading process, that would never necessarily come to the surface. So what we're doing is training an algorithm to go through and to read the text and then find the key themes, but also find specifically people who are actually saying, look, here is something that makes you think you've got a mental health issue, a life event, something has happened in your life. And when we do that, the council can then start to say, well, are these two groups being treated equally? We'd like to think that the people who say they're vulnerable are being treated as well as the people who don't say they're vulnerable. And the thing about what people say is it's what's important to them, right? I have decided to tell you something. And I think why I was really interested in this project was that I never asked the question, how good is the algorithm at really spotting that? because I'm prepared to bet we are not using training data that trained the algorithm. I bet it never had vulnerable customer input. Given most of these algorithms are developed in America, it's probably chat between Harvard students, and it's not the community that we seek to serve. So that was why I was really interested in your project, and delighted to be involved.
Fantastic, and you've hit on one of the key aspects of this project. But really, once you sort of talked about, we were like, yep, that's exactly who we need, and they seem to understand what we're doing. And that is understanding how well these tools actually work. In the first instance of analysing this data, so is it an effective way of speaking to a large group who have communication difficulties or circumstances that affect the way that someone might talk about care compared to someone who doesn't have those circumstances? But then two, how is that going to affect what is quite an important sort of provider organisation system around that, bearing on its different levels? Maybe this is a strange way of putting it, but despite what some people say, I am a human, and I do a lot of research for Coproduce Care over the last few years. A huge one recently has been vaccines. So just as an example, we have two types of data from that. We have people clicking yes, no, maybe, very, very, very likely through to very unlikely about how confident they are in vaccines, how confident they feel in the information around it, yes or no about a decision like making vaccinations mandatory, where we can very easily make statistics and then start comparing those statistics between groups, and that's very easy. We also have questions where people would talk openly about vaccines and their confidence, concerns, issues. And then again, as a human, I would have to go through each answer, start making notes about what I see come up a lot, then go back through and say, is that true for everyone? And if that keeps happening, we can say, yes, that is something that's significantly come up a lot. We can talk about it in reports. Where in between those two is what is the computer doing in between those two?
Yeah. Well, what is the computer doing? So what the computer doing is reading the comment, and it is looking for key phrases. Now, the key phrases are extracted because the algorithm has been trained to recognize them. And effectively, the algorithm we're using on your project is a thing called Microsoft Cognitive Services. So Microsoft actually make available a service, and you can basically send it a sentence, and it will come back and tell you what it thinks are the key phrases in that sentence. And so basically, each time you send it, you get something back. And why we like that is because everybody understands Microsoft, and they charge you based upon the number of times you use the service. There isn't a fixed cost for getting involved. And to give you an idea, with the council every month, our bill is about £18, right, for actually having it automatically analysed. Now, the question is it any good? Is it worth even £18? And so, you'll get a phrase where somebody says, I'm a single parent with an autistic son. Now, what you really don't want the algorithm to do is pick out parent and son, because it's completely missed the point there. We had one example where somebody said, if I'm being frank, I'm feeling suicidal. And the algorithm pulled out Frank. This sentence is about Frank. And it didn't recognize, the significance of it. And so, you then had to do some workarounds, some ways of doing that. And so what we'll find out is that basically with this methodology, we'll find out if it recognizes what people in your world actually say, and whether it's useful. Because if it just comes back with I'm a single, it comes back with parent and son, it's not very helpful. But actually it's a very different conversation if somebody's told you they're a single parent with an autistic son. So it will be really interesting to see. And whilst you can do a sort of a handcrafted job, that's not scalable. And I think that was one of the things that you really impressed upon me, Arnie, is that we're going to do this. It has to be something, we have to choose a technology stack that people can actually use. So we will get the survey questions from you. There is a little bit of Python work, so Python being the most common programming language, the simplest programming language, that will take each sentence, send it to Microsoft, get an answer back and store it. And once we've got that, we actually will put that into a big spreadsheet. It'll be quite a big spreadsheet, but it's still a spreadsheet from which we can then do a visualization in something like Tableau or Power BI. It doesn't really matter which tool that you choose. And by doing that, it makes it a recipe that other people can do if it recognizes the language.
Excellent. Yeah, so we've got the one key test of its effectiveness there, i.e. there's a group that maybe doesn't speak in the same way that students in Harvard speak. So how well does the coding that exists in there understand that group? How well does it summarize what's being said over a large group? And also, thanks so much for being confident that we're going to get lots of data. That's a good bit of support for me. But the second issue with the coding itself is a wider bias. So taking it out of the group that we're talking about here, i.e. worst outcomes, people that are kept out of decision making and monitoring when it's humans, other sides of tables, developing care plans and care systems across a region. Even when these tools are being used in wider society, we're seeing very, very big challenges in the way that the views and unconscious assumptions of the people that code them affect them. Is there any comment you could give us on those wider inequalities and the way you're seeing that in the way these tools have been adopted in quite a few different places?
I think the key thing is that once you have got key phrases, it is down to us then to consolidate those into groups, because you've got to do a little bit of work. So key phrases come back. A good example of that was bereavement. So there are a number of different key phrases. Now, people were clearly wanting to talk about this, but they would say somebody has died. That would be a key phrase. Passed away would be a key phrase. With the angels was a key phrase. And so basically by listening, you could bring those together and group it into a group of people who've recently been bereaved. And that was not something we could ever do before. So in order to sort of get the themes, the things that people want to talk about, the machine has summarized it, but you still have to have the human being to go through it. With the council, we were asking, the last council, we were asking them what the themes were that they would like to understand. And then so that was, we call the top-down approach. These are the things that we think are important. And then one of them, for example, was trust. We were coming from the bottom up. Nobody talked about trust. The most common theme people talked about was waiting time, right? Nobody had ever said waiting times from the top down. But when you said to people, we had thousands of people who were saying it's waiting time. Now, I'm not going to talk about trust if I can't even get through to you because I'm waiting to speak to you. So in order to sort of understand, there's a human element, and you've got to listen to what the key phrases are. It enables you to do that and then to summarize it. So what we do in the analysis is then say, okay, every comment has got these key phrases. Which buckets do these key phrases fall into? And then now let's look at the buckets and see what people are talking about.
Excellent. So there's multiple layers of very sort of unintentional but equally damaging sort of bias that can come up in the application of these tools. Not only in how they're basically coded in themselves, so how it understands something to be significant. What was the example I used? Arm and a leg. Someone is worried about injury or cost, that can get confused, but if you're looking for data about injuries, then you might start misunderstanding. If you're looking for information about costs, then you're going to misunderstand. The application of the tools themselves, then who's deciding to use them and when, is loaded in itself. So what information is gathered and how it's analysed is a whole separate layer, which hopefully we'll be able to go on to in a lexical section in a minute or so, as Katie gets ready to join and talk about the sector context. But maybe if we just finish your sort of 15 minutes with a worst and best case scenario. If we're seeing it work well, when we first put tests through, and I don't have much work to do afterwards, that's because we've seen what, Matthew?
Yeah, it's because the algorithm has recognized what has been said. So the best case scenario is the algorithm recognizes enough, because I don't need to capture everything. I just need some comments flagged to capture it. So it's a bit like a net. It doesn't have to be perfect. And then clearly the best case scenario, what I love about your project, is that you are going to release the data afterwards so that other people can stand on our shoulders and improve the technique. So I think the best case is really good. There is no worst case, because the worst case is we'll be knocking on the door of Microsoft to say, do you realize your algorithm does not understand the most vulnerable people in society?
Absolutely.
Nice to be.
Great. So just before I go to Katie, I might sum up how our project works over there. You also mentioned a couple of things that I'd like to calm the people that fund us and have organised this project. I won't trust what the computer has said once we tested all the data through the machine learning and sort of text mining techniques. Our job then is to go through and proof it. So we are not only, as Matthew's saying, they're releasing data, so it's an anonymous bank of people with these circumstances talking openly about care is then available to anyone to do any kind of analysis on it. We're done completely anonymously and sensitively. But once those first tests come through, we have to then understand, do I agree with what the coding has seen as a significant topic of conversation in there? Do I think that maybe they might have been saying something else as a human that has engaged with people in care scenarios? And then also issues about how that has understood people in different scenarios, different settings, different places differently, and what issues that are going to cause. There's also another aspect we've not talked about where we're carrying out specific data collection for sort of a diverse ethnic group, so that we can almost build in enough data so that we can make that comparison of an issue that we suspect is going to be something that the coding might struggle with. So thanks so much, Matthew. If you have questions about the tools and the techniques we're using on the technical side, we will be joining back together as a group in about 15 minutes to chat openly and look at the questions through the chat that Josephine's keeping an eye on. So carry on posting any for Matthew there, and we'll get to them in 15 minutes or so. Katie Thorn, great to see you. Good afternoon. Thanks so much for being with us. How are you doing?
Yeah, all right. Thanks, Arnie. How are you?
Yeah, not too bad. Bit muggy and been running around with things like this all day, so a little bit unsure as to what I'm saying makes sense to anyone, but hopefully it does. Just for that bit of introduction again, then we've engaged with Katie in a couple different ways over at Digital Social Care, through everything from smartphone sort of guidance to how to make staff confident about technical developments, understanding the differences between different parts of care, and has been really gratefully happy to engage with us on this to do some of that wider engagement work, which will be a huge part of this project once some of those first tests have been done. Katie, would you like to introduce Digital Social Care and yourself a little bit more for a minute?
Yeah, sure. So Digital Social Care is a partnership project, which is care provider led. And we're funded by initially NHS Digital, and we launched in 2018, and then more recently NHSX. And our sort of core focus as a team is to provide free support and engagement to adult social care providers across England on anything to do with digitalisation and sort of information sharing more broadly. So all of our team have come from the sector. We're not tech experts per se, though have learned a lot, obviously, over the last few years. And so we do that in two sort of core ways. We have our website, do lots of engagement events like this, and sort of have lots of information available there, free helpline that care providers can call. And we also work really closely with Department of Health and Social Care, NHSX, ADAS, LGA, to try and help represent care homes, home care, and the wider care provider sector in conversations about digital strategy.
Great, thanks so much. Now, the reason why I was hoping you'd be able to take part and be a part of this sort of part of the conversation is because of that final bit of the project that we are putting into this, that wider sector learning, that engagement across parts of the sector, different levels, different types, different sort of levels of seniority also. What do you think is the issue in saying, right, over the next few years, data is how the social care system is going to work. I might give you a little clue as to a project we did a couple of years ago when we were trying to get things like Microsoft Teams and remote care planning pilots in sort of community settings. One of my favourite anecdotes from Matt was a care and support worker, as part of a pilot, went round and filled out, was expected to fill out their normal sort of forms and reporting on a device, as opposed to the forms that were a more conventional way of doing it. What we found was that they were writing it down all day, keeping that record for themselves, getting to the end of the day and typing it all up in one go as part of a sort of to-do list. We also found within a small geographical area, some people already using remote working and digital care planning softwares, and some people still using sort of fax machines, paper, and hard copies and things. Is data going to be problem-free for the care sector over the next couple of years?
Yeah, absolutely. There's no problems. You can stop my section. No, I mean, I think, as you say, it's a very sort of mixed bag out there right now. So there's a really interesting report done by Institute of Public Care, Oxford Brookes University, I think back in 2017 now. They sort of broadly said that there are 3 digital personas for social care providers. So 1, completely paper-based, 2, sort of mixture, some paper, some digital, and then 3, completely digitized, never have to touch a pen again. And probably unsurprisingly, not many people are quite at that end, fully digitized yet. So it's really, really varied as you go across the sector. And we've done sort of quite a lot of research in this, and actually have a report coming out next week, which we worked on with Skills for Care, which looked at a representative sample of care providers from across the country and sort of how the last 12 months has affected digitization, for example. Unsurprisingly, we've seen sort of massive accelerations in the adoption of technology, especially video conferencing, which has become pretty ubiquitous, obviously. But we're still sort of only seeing under 50% of the adult social care provider sector using electronic care planning or using any kind of digitization for care recording in any way, which means it becomes quite difficult when you've got such a fragmented sector and a lot of the information is still on paper to do the sort of analysis that Matthew and yourself are trying to do. So yeah, it's got quite a long way to go, not only in terms of just adopting the technology, but also their digital skills, I think, for a lot of the workforce who are brilliant at their jobs, but aren't necessarily used to using technology day to day, as you said in your anecdote. So we've got quite a lot of work to do around that skills development, as well as just sort of adopting technology, if that's the route we're going to go down.
Absolutely. What would be really interesting here is thoughts on those 2 levels. So as you said, there's the basic behavioural change, I guess, of doing it differently to how you've worked for the last 1 to 20 years. Day to day. There's also confidence in these systems. So I don't know if anyone was listening to Matt Hancock's evidence today, but even as the sort of lessons learned conversations are going on, data is seen as the solution. So it's very difficult to see how this won't be a huge part of the sector, which means you have to engage providers, organisations at different levels of the sector and say, well, this is now a safe and efficient way of us working together nationally. So you've got the behavioural change of how you do work, and you've got the confidence in systems that are going to be collecting a huge amount of data, passing through a few different hands and making decisions about care on different levels. What has sort of maybe worked well or been the clear challenges you've seen, either on that behavioural level or in that engagement, building up that confidence? I ask you because I'm going to be spending months writing up learning and templates and policies, but promote providers getting involved in this. So what should I put in those documents?
Sure. I'm going to tackle the behavioural one first, the confidence one first even. I think we have a real issue in that we don't really articulate the benefits and the value creation which we get from this technology particularly well for people in the sector. Quite often, and I spend a huge amount of time, as I'm sure everybody on this call does, reading case studies and reports which talk very well about sort of system-wide benefits where appropriate, but actually for an individual care provider, that's not always particularly clear for them. You know, we can talk a lot about the improved care, and then as a registered manager running an outstanding service, you go, well, we're outstanding already. You need to give me something more. You need to articulate this more clearly, particularly when it involves a full cultural change in how you're running a service quite often. So I think that's sort of a barrier that we need to work with more, and actually have more people from the sector coming forward and telling their stories about how they've adopted things, why they've done it in the way that they have, and being really involved in having that voice for the sector. So that, for me, I think is sort of going to be a key component for your project going forward, and why it's really important that you are, Manor Community as a care provider, you're involved, you have that voice, and it's not just sort of something that's being done to you, it's something you're proactively engaging with, and I think that would be really, really helpful.
Great, and again, it's great to hear that. Great support for our project again. But there's two levels that we see being a provider leading on developments like this, especially the use of data more and more, not only in sort of recording how care is done, but in sort of informing big decisions on different levels. I see two very different strands of ways this could go. It could be a mix of them, but sort of be a bit extreme. In the best case scenario, the more data is used, the more confidently providers can work together, because there's a platform to report together, to understand what's going on across a region together, to speak with other parts of a service, maybe health or local authorities, and be a part of that conversation of how is care doing, where are the gaps, what changes would work, almost becoming an autonomous, connected system. And we get a little bit closer to health in terms of sort of parity of esteem, the skills, the careers, and the opportunities here in care.
Yeah, I mean, I absolutely agree with that. And, you know, there's been lots of steps that have been taken in sort of over the pandemic, like the uptake of Capacity Tracker, for example, is probably the biggest uniform data collection from the social care provider sector that's ever happened. And, you know, that's been mandated in response to incredible extenuating circumstances. None of us thought a pandemic was coming. But while care providers who we speak to and we interview as part of our work with this can really see sort of how this benefits the system, for them, they don't get any information back out of that helps them on a local level. So actually having that conversation, being part of a collaborative ecosystem working together, I think is one of the strengths data can have if you've got a voice of all the partners at the table.
Absolutely. And that is a huge opportunity. It's something that we already hear in conversations around this. People who are excited to be involved in the project see that, they talk about it, and quite rightly, it's an opportunity we see. On the other end of the scale, there's a couple risks. One would be misuse of that data. Quite rightly, people might be scared that all this is just creating a big profile of how people across communities in some of the worst circumstances up to anyone affected by health and social care now has a profile somewhere that can be looked at, that can inform, again, a sort of extra layer of what we were talking about with Matthew a few minutes ago, of then how that data is used. I mean, agenda is a bit of a horrible word, of the people that are then using that data. So if you're looking at it nationally, you then have to make decisions about how care is funded and delivered nationally and supported nationally based on where it comes from. So you're obviously, does it work accurately? Has it represented what people said accurately, or what's actually happening? And if it's not feedback data, a different form of data is used, is it accurately representing what's going on in care? And then two, is it being used to make care more efficient, fair, inclusive, or is there sort of profit to be made in how you manipulate that data, or sort of a more efficiency focus on priority that might not be as focused on provider improvements and inclusivity. I also see an issue in the way that this might be rolled out in some places and benefit some places more than others, either geographically or in the sort of setting of that care, i.e. in a rich city compared to in the countryside somewhere that's not so affluent. What do you think is the biggest risk for the sector, maybe out of those or your own, or are there ones that you're seeing come up a lot, or sort of being able to assuage from speaking to providers?
Yeah, I mean, I think all of the things you've mentioned are really, really valid anxieties and things I think we need to be concerned about. I think for me, one which does really concern me is about possible difference in access to these kinds of information systems and how they work dependent on the sort of region that they're in and how that's run. You know, we talk a lot about funding in social care, and I don't want to get distracted on it, but the reality is if we're going to start digitizing more as a sector, some of these systems really do cost quite a lot of money. And if you're taking local authority funded or NHS funded residents or service users, can't necessarily afford to invest on quite the same level. So for me, like that possible sort of widening gap of inequality of experience and outcomes which could come is something which really concerns me. And also, I think it's kind of come up recently. We've seen a lot in the press about the GP data collection for research and planning and all of the backlash that's getting. I worry about sort of a loss of confidence in the sector about this data collection, and that the general public starts, you know, losing that trust, which is so important in how we're providing day-to-day care to people. So I think that's a real concern.
Yeah, I remember even 5-6 years ago, once the sort of ethics of robotics and collective augmented or autonomous decision making was hitting the sort of academic field. People in engineering was suddenly going, oh, people don't like data on every part of their life and behavior being taken and used. Like, they weren't going to do anything bad with it. It was only to improve the systems and do it. But it was sort of like, oh, people don't want all this data used. So even that conversation in itself seems to be something that maybe needs.
Yeah, and we see that quite a lot. So I was the care home lead of the recent professional record standards body project looking at interoperability standards between health and social care, and got to take part in some of their public engagement events, which were really, really interesting. And that was talking about information flowing from hospital to social care settings for people who need social service funding. And there's a lot of really interesting conversation from members of the public and people receiving care about how they'd be happy with some bits of data being accessed by the GP or the hospital or even the carer providing care. They didn't necessarily want that flowing to the local authority because they're concerned it affects their funding status and that sort of thing. And so it's a difficult problem, but I think these conversations are already starting to be had, which is really positive.
Excellent. Just going to ask Matthew to pop back in now. And just for a minute or two, remind everyone that the chat is there for questions for us all. Now, for the remainder of the hour, we're going to have a guess of how good or bad this is going to turn out over the next few years, what it's going to look like in different places, and one of those things that we need to be thinking about as that happens. So please let us know if there's any thoughts, comments, questions. Josephine's keeping an eye on, and we'll make sure we get through them. Just to start though, Jackie Morton's just popped in a really interesting question. Have things moved on though? Now people are more used to sharing so much on social media. Now, I might go to Matthew, then Katie on this, because it brings up a huge question for me. Like, well, bit of a devil's advocate question. What's the point of this project? Is it worth it? Is data even going to be a big thing in the future? Is it being used anywhere? Matthew, that chimes to me that it's already happening. Wherever there's data, it's already being sort of processed and used for analysis on a big scale and then informing decision making in different places. Is that true, or am I a bit too paranoid?
No, I think data is being used in ridiculous places, and when you look at your web browser and see how many organizations are tracking you, that if you visit the Daily Mail website, the Mail Online, something like 200 organizations get alerted immediately. So that data collection is there. But I think the thing that I think Jackie's point is right, that many people have moved on. There are others who haven't. And I think the thing that I would keep on saying is, let's use anonymized data. You get such a long way with anonymized data. And by anonymized, I mean there is no way back. The algorithm has changed the numbers, so you can't get back to the original people. You've cut out the small numbers in your data set, but you can still drive change. You can still show people things that are happening. You can tell remarkable stories with anonymized data. And if we get people more comfortable with anonymization, we can then take the next sort of step, which is to pseudo-anonymization, where nobody can get it back apart from the owner of the data. And then, then you start to build it out. And I think, part of the problem the government's had with the GPs at the moment is they haven't explained what pseudo-anonymization is. And, there is, only person who can get back to your record is your GP. Other than that, you've become a random number that nobody can work out on. So I think there's a huge amount that can be done. And we mustn't get too hung up about having the name of the person. We can say, okay, you know what, and if it's really worthwhile, if we do some analysis and you discover something that really then needs you to go to the next level, well, actually, we've now got a use case that says we can do good if we anonymize, but we have a price, and the price is taking away privacy. But until we have that sort of use case, it's very hard to work out.
Perfect. Katie, any quick thoughts on views generally on privacy and data use that you've encountered before we go to Josephine to let us know some of the questions from the chat?
Yeah, I mean, I think I would agree with everything that Matthew just said, to be honest. Obviously, data privacy is a huge conversation and has been for years in sort of the circles I move in, but I'm not certain necessarily that's the general public. It's something which is always particularly at the top of the agenda. And as Jackie said, I think it's a really valid point. People are used to sharing parts of their lives through social media nowadays. And I think this is why it's important to have a public conversation, as Matthew said, about this, right? To make sure people are really aware about what the technology can do in simple terms, who will have access to it, and, all of that sort of side of things. When we try and hide things behind technical terminology and legal terminology, I think we have a tendency to go, oh, well, we legally can, rather than thinking, but ethically should we? And I think that's an interesting conversation to have as well.
Yeah, maybe just one more anecdote before we go to Josephine then for the questions. Again, bringing up the vaccine research that we've been doing in Coproduce Care for the last few months, what we found time and time again, what people said might not be the truth, but even if the information about vaccines wasn't complete, even if we could only say, oh, it will be a few months coverage, there's a chance there'll be booster vaccines, there's a chance it will affect this, that, but this is what we know now, that improved confidence in people more than saying, we can't tell you until we know more, and don't include any information other than what we want to go out. So that co-produced conversation, if you're noticing a theme, is a hugely important part of how we see confidence being built on all levels over the next few years as data get used more in the sector. Josephine, any great questions from the chat for us to go over now?
Yeah, I think this one is for Matthew specifically, which is from Katerina. And it's who writes these scripts and in what occasion could different communication styles matter for the algorithm and unintentionally exclude certain groups? Where does the data come from?
Yeah, so I think all of the above are true. So the script for the asking the question is very much written by Arnie with understanding of the sector. When you then get into the algorithm is basically derived by Microsoft, and so it will have its built-in bias without a shadow of a doubt. But on the other hand, we keep on trying to beat it on our own. And I've learned that me and my team can't beat $1 billion of Microsoft research and development. We keep on hoping that we can. So the algorithm there is, we think, pretty robust. But it's this trade-off again. It's accessibility. It's something that everybody can use. Whereas actually to do it on our own, I've got to have a data engineer and a data scientist writing this. And most people in the sector don't have access to those people within their organizations or their suppliers who could do that for them. And it would kind of be like reinventing the wheel. So I think the notion of get Microsoft and Google does this and Amazon and all sorts of people, but get that world to be better at recognizing the people we care about and understanding is the way forward. It's influencing them, because then the technology becomes so ubiquitous. It just becomes embedded in things, and you don't have a conversation about artificial intelligence just because a forecast appears. Now, how it's created or an analysis occurs, how it's actually powered, you don't really need to know. kind of like electricity, it just works, and you'd like it to be something similar. Does that cover the question?
I like that answer, and it gave me another chance to shout out about our project. That is the 2 levels we're testing. The first initial test is, has it understood this very important group that are often kept out of decision making and conversations about how care is run? Does this technology understand those groups, and does it help to look at a large amount of people's answers or open conversation about care to then start pinpointing gaps, issues, changes in delivery, funding, support, initiatives, anything like that? Second of all, are there differences in that? So age, where are you getting care? Are you care home, supported living? Are you inner city? Are you outer city, suburban, rural? Are you a white male or are you not? We can start to compare how well that tool has worked in this setting, and we can say, hold on, there's a huge issue here. It doesn't understand people, and it's not very good at understanding language from a certain culture or age. Or, hey, Microsoft, you've got a great, fantastic tool. It works. It can understand people. Now, sector, here's the learning and the policies that are going to make providers feel confident that they're a part of this development and are leading in a way that it creates that conversation and sort of evaluation of how care is delivered. Casey, did you have any thoughts, or we'll go to the questions again? Okay.
That's great.
Thanks, Arnie. And I think that also takes care, to some extent at least, about a question around validation of this and how that is done. But I have something else from Daniel Casson, which is, I did some work earlier this year with NHS digital data analysts who said that the real value in data would be if data from about a person in a care situation was matched with data in their health record. What are the issues that the panel see with that sort of statement?
Excellent. I would love Katie's thoughts on this. Interoperability, collaboration, and bringing parts of the sector together is a huge aspect of this. What's the answer, Katie?
Yeah, and thanks, Daniel. He's a colleague of mine for this question, putting me on the spot there. Yeah, I mean, I think it's a really interesting question about what we're talking about, the real value in data from data analysts, because from a direct care provision point of view, there's obviously lots of benefits to linking up health and care records so that people can get access to the information they need when they're providing direct care, regardless of where somebody is in the system. I mean, I think it's fairly self-evident and well understood. I guess for me, it becomes more problematic when we're just saying from a data analytics point of view. That's why we need to be linking up these data sets, because the kind of data that we collect in social care, generally non-structured, very much more around sort of activities of daily living and sort of outcomes focused on continuing care rather than sort of crises events. And I think that needs to be considered quite carefully about how these data sets can be matched up and if that's meaningful to do. I'll leave answering that question to probably Matthew and team who are more technical than me, but that's sort of my initial thoughts really is, yeah, for direct care purposes, I'm totally on board, but I think more broadly, we have to be careful.
Excellent. Yeah, Matthew, if you want to give your answer before I sum up, I would also just like to jump in and say that there's quite a bit of background to that question that is almost loaded. It's a long-term issue within social care to understand how we match up to health as a sector. Like, it's the Department of Health and Social Care, but that and social care does get dropped a lot of the time. There is maybe an argument for a lack of understanding of the social care sector to the same level as health. It's seen as a similar sector that works the same, but it's in homes and care homes as opposed to hospitals. It's a very complex sector with different activities in different settings, in different levels of sort of connection to local authorities. You can have a sort of community care that's completely out of there. And I think that complexity is a huge issue in connecting health and care. But Matthew, please, yeah.
I think it's an interesting question from Daniel, because I think the other piece here is that we sort of need to separate operational activity from analytical activity, because for analytical activity, I can work with this pseudonymized data. So earlier today, I was talking to the National Association of Primary Care, And basically what they were interested in is, how do you work back? There was an unplanned medical episode. How do you work back to find the root cause? Now, exactly to the point there, you can only do that by joining up data. So if somebody has an unplanned episode, we can go back, what happened with their GP, then you can go back to their home, to their employment, to their education, to a whole myriad of factors that led ultimately to an unplanned intervention. You've got to be able to join data to do that, but you don't need to know who it is. In fact, if you've got one person, it really doesn't help you, does it? I need a cohort of people. So I think that's an important sort of separation. Operationally, if I want to find these people, then I absolutely need to know who to do that. But that's very different from analytically, and I think we need to make that separation and get people to use more anonymous data. And just to say, yes, I've done a project actually where we have done the D2A process in a county where you could actually understand that journey from health into social care. And I think it was the first time that we turned the lights on so that everybody could see the flow through the system, that everybody was at the table. I think it was Katie's point earlier about making sure that everybody gets payback from being involved. And so for the first time, we could turn the lights on, not on the little silo which said, did we discharge people at the right time? Or what was our KPI for doing assessments? But to actually see the experience of the resident across the entire journey. And that felt like a eureka moment. And again, we'd started with known data, but along the way, it had all become anonymized. So there was no way you could pick out individual people in that data. So therefore, it felt really good sharing it with everybody.
Excellent. And yeah, we are going to wrap up now, so I'll do my sort of final comments. Thank you there, Matthew. You've brought up such an important example with discharge to assess. Obviously, we've had conversations about that co-produced care over the last year in lots of different ways, how it's affected the sector. But I think that is the key example of the two opportunities, or the two ends of a spectrum of opportunity that's going to come from increased data use and automated analysis of that data in social care over the next few years. Is it used, exactly as you're saying there, to get a huge flexible picture, reacting to a region across space and time, different people's experiences throughout their life, throughout different engagement with different services, so that we understand that better and we can react and create systems that react to that appropriately? Or is health got a very efficient way to say who's efficient and who's not efficient at getting people out of hospitals, which in itself is a very biased way of understanding what social care does. So thank you both so much for being a part of this. As I said, there'll be a huge amount of engagement later in the year once we're getting those first results of the tests in our project itself to see how the machine learning has understood adults from this very important group, how that leads to recommendations that can be provided to a council, and then really importantly, what is the learning, what is the policy, what are the templates for training or internal sort of changes that are going to mean providers feel a confident part of these changes in the future. Would just love to shout out, obviously, Digital Social Care and Logan, Todd themselves, really helpful, incredible organisations. Also, if you get a chance to follow Coproduce Care in any way, if you check us out on the website, you can subscribe to our mailing list and you get all the updates of this project and lots of free, accessible sort of content and democratizing the care debates activities in different ways. The vaccine report's just come out and we are going to start engagement on this project in a huge way as we move on to summer. And yeah, just leaves me to thank Josephine over at Future Care Capital for helping set up this event. It's been really incredible, very exciting engagement and event. And yeah, have a fantastic afternoon, everyone. I hope you stay safe. Take care out there.